So all of you are familiar with looking at the electrocardiogram. So globally, it looks at the wavefront of activation, whether it's from right to left, left to right. So if, for example, inferior wall myocardial infarction, the changes are in the diaphragmatic leads. So the orientation is very similar. So if you take two electrodes and there are several electrical noises from head to foot. How do I think? It's some cerebral activity which is an electrical signal. Electromyogram, it's a different electrical signal. If you set the electrical frequency to 0.01 to 100 hertz, you pick up the electrical signals that come from the heart. And that is what the ECG does. When you set the filter setting, you ignore all the electrical signals, EEG, electromyogram, and selectively tune in and pick up the myocyte potential if you set up that frequency. What we do in the electrocardiogram or during an EP study is try to look at the electrical signals between two electrodes, just two electrodes which are 2 or 4 millimeter apart. Instead of looking at the whole electrical activity of PQRS, you are trying to see just underneath this electrode. For example, proximal electrode, distal electrode, what is the local electrical activation? Now, how do I do that? I change the frequency. Instead of 0.01 to 100, we make it as 30 to 400 hertz. Then you ignore the T waves, you ignore the P wave, you ignore the diaphragmatic oscillation. All those are at different frequencies. You selectively look at the frequency of the electrical activity occurring under the myocyte. And conventionally, we place the electrodes. This is a cartoon showing in high right atrium at the region of the right tricuspid valve to look at the His bundle activation, along the mitral annulus where we place it along the coronary sinus. So globally, you will know what is happening depending on the area of interest. Suppose you have a person with a left lateral accessory pathway. The main catheter for me would be to record the mitral annulus so that I can narrow down and find out where the electrical activation is. Suppose I want to look at some kind of a paraseptal or a parahisian pathway, then the His catheter is very important. You cone down and see what is happening there. So I think all of you are familiar with this. When there is a recording electrode, suppose I have a recording electrode at point A and stimulate the electrical, the wavefront of activation starts from here, and what you see is depolarization and what you see in blue is a repolarization wave. As the wavefront of activation moves from point A to point B to C, if I am looking at it from this side, all the electrical activation is moving away from this. This is what a unipolar electrode does. Unipolar electrode doesn't tell you the timing, but it tells you the wavefront of activation is either moving away or moving toward. Suppose the same wavefront of activation, I am looking at it from point C, I see all the positive charges coming towards me, and therefore I will record a positive deflection. Now this is the intrinsicoid or intrinsic deflection where it crosses just till this point B, the electrode keeps coming, the charges keep coming here. It crosses the baseline and moves to the other side. This is a baseline crossing where exactly at that side it becomes a biphasic kind of a wave where it crosses the point of recording. So this is extremely important when you try to map a focal arrhythmia. I think all of you from your physiology days know that broadly there are two types of arrhythmias. One that starts from a focal point and fires very rapidly, just like sinus node. Suppose you have a clustering of cells somewhere in the atrium which automatically goes and starts firing rapidly, that is automaticity. But 9 out of 10 the mechanism is re-entry, like going through the AV node, coming through the pathway, or like an atrial flutter. So let's first start with focal arrhythmia. Suppose you have a patient with a recording electrode there, and the wavefront of activation, your recording is just on the site of activation. Then you will find that you will have a completely a QS complex, and this descent, which is called dV by dt, is very rapid at the onset of activation. Suppose my electrode is here, I will see an initial positive deflection that tells you I am not at the site of origin, I need to move the catheter to the site of origin so that I localize where it's coming from. So broadly, I'll tell you how we go about in the EP lab. Suppose you have a focus of an arrhythmia coming from here, and we have 6 electrodes here, which is recording. Suppose I take a far field view, that is a very wide view from 1 to 6. You see that their earliest, this is the, say for example, the QRS. In a person, the beginning of the activation starts in a global activation somewhere here. But you want to fine tune and understand which is the smallest electrode which records the electrical activation early. And that seems to be, for example, unipolar 1 is late, unipolar 3 is late. As you come down, between 3 and 4 is very early activation. Am I clear? So then from here I know that it is somewhere here. I pull the catheter here and move this way or that way till such time I reach the point of origin of the impulse. So this is the way you navigate. You have a concept of a 3D geometry of the anatomy of the chamber in which you are navigating, and then move the catheter either forward, backward, anteroposterior or medial and lateral, so that you can fine tune and get this. Now this degree on the modern day electrophysiology, we didn't need to do all these things. The computer does it for you. In the olden days, we used to use and remember that this is where it was and keep moving. Whereas now the 3D geometry is connected by a 3D mapping system. So again, to emphasize the low pass filter, we set it usually about 500 hertz, and below that it will allow all the frequencies to pass through, and high pass filter is usually 30 hertz, and it will filter anything in between is what we record for recording a smooth electrical. Usually this kind of a rapid deflection is seen in the AC mains, which is usually 50 or 60 hertz noise which comes from the AC current, and that notch filter will take out all that noise and will give you a crisp electrical signal at the point of activation. Now again, high pass filter will allow all the lower frequencies will be filtered out, and then you see this. Again, this is, for example, a respiratory oscillation is all filtered out and you get a crisp electrogram. So basically, when you look at the sequence of tracings, you have the recorders which runs it at 50 or 60 millimeter per second speed, and various electrodes. For example, the conventionally for a supraventricular tachycardia, we have a high right atrium, His bundle recording, and then the coronary sinus. Now looking at this, the P wave where it starts, the high right atrium is the earliest local electrogram, and then the low right atrium, followed by an isoelectric interval, which is the amount of activation that happens in the AV node, which doesn't inscribe any electrical deflection, but that is inferred by the AH interval. AH interval tells you the amount of time it takes to go through the compact AV node, and then generally about 10 millisecond is what, because the His bundle is a very rapidly conducting structure, all that it takes is less than 10 to 15 millisecond for the whole His bundle activation to get over. If it is anything beyond that, that means your His bundle is diseased, where you see a splintered His bundle complex, and then because the His is an insulated structure, till it goes and activates, I think all of you are aware, at the non-coronary cusp and the right coronary cusp level, you have a penetrating bundle of His, and from there it is like an electrical cable which doesn't dissipate the charge. You can't see anything there because it takes all the current to the distal left ventricular septum, and that's where the depolarization happens. So that is why you get a HV interval, where the electrical charge that you are recording here is silent here till such time the ventricular activation happens. And usually the ventricular activation first breaks through in the left ventricular portion of the septum, somewhere between 2/3 and distal 2/3 of the septum. It breaks through, and then you get a ventricular activation. Again, what you are seeing in the coronary sinus is all left atrial activation from proximal coronary sinus to the distal coronary sinus of the left atrium. This is the far field left ventricular activation, which is far field because it's blunted and it's of low amplitude. Compared to this, this is a near field ventricular activation of the right ventricle. So this is right ventricular activation, this is a left ventricular activation. All these things you can infer. Suppose you have a person with an accessory pathway, you are likely to see the ventricular activation at that site to be very early, and that's where you localize the accessory pathway in that patient. So again, where to measure the intervals, I think I'm not going to go through this. For people who are entering into EP, these things are important. But nevertheless, there are standard ways to measure these intervals. And even to record these A, H and V, you need to position such a way that you get a equiphasic deflection of atrium and the ventricle when you record the His. Again, this is to amplify what is going on, and in these patients, we bring in extra stimuli to stress the conduction system. For example, when a normal strain of impulses are given, the AV node accommodates to a steady state level. That is called S1, S1, S1 at a steady state level, and then we bring in an extra stimuli at a shortened coupling interval, and that time suddenly you find the A is inscribed and then the no hiss, A hiss and V, here the A no hiss, indicating the block is at the level of compact AV node. Okay, suppose I had seen A, H and no V, I know it's an infrahissian block. Whereas if I see A but no hiss, that means the block is at the level of the AV node itself. So this is how you try to interpret what is going on. Again, this you would have learnt again and again about AH jump. What exactly happens is, again, this is a cartoon from what you are looking at, coronary sinus os. The compact AV node is somewhere there, and then the His bundle. In a normal sinus beat, the impulse comes rapidly and activates the His bundle, AV node and the His bundle, and that is the fast pathway. Compared to that, a very slowly conducting impulse comes in the floor of the coronary sinus and activates the slow pathway. Now, how do you understand this is when you start bringing in extra stimuli. For example, at a coupling interval of 350 millisecond, you find A, His and V. And then I just shorten this by another 10 millisecond, you find there is a significant jump in the AH interval. You saw that the AH interval was 350 millisecond, and suddenly it jumps to more than 400 milliseconds just with a 10 millisecond decrement. And not only that, the impulse that has gone through the slow pathway has turned up and started setting up a re-entry in the AV node. So this phenomenon of a brief jump in your AH interval tells you that the impulse has shifted from the fast pathway to the slow pathway and set up a re-entry called AV nodal re-entrant tachycardia. And what are you seeing here? Each pacing stimuli is followed by an atrial depolarization. You see a pacing spike, a atrial depolarization, an atrial spike, atrial depolarization. Here, when you deliver the pacing spike, it hasn't captured the atrium. So the block is at the level of the atrial tissue itself. So this is atrial ERP. So you saw an AV nodal ERP. Here you see an atrial ERP, and this is how you determine the refractory period. The other common thing that we need to do when you start a study is pace the ventricle. When you pace the ventricle, in all of us, physiologically, the impulse will go retrogradely through the His-Purkinje system and then activate the AV node and then go back to the atria. So that is called as a concentric activation. What is concentric activation? Is the impulse that you pace from the ventricle retrogradely goes through the His bundle, AV node, to the low right atrium followed by high right atrium. That is concentric. So let me again recap. I am pacing the ventricle. You can see the ventricle getting captured, and the earliest atrial activation is at the level of the His, and then the high right atrium and the coronary sinus gets activated. So this is concentric. On the other hand, look at this example. We are pacing the ventricle, and then when I am pacing the right ventricle, the earliest activation is in the distal coronary sinus. The A here gets activated before the level of the His. So this is not possible in a normal AV nodal retrograde conduction. This tells you that the conduction is going through an accessory pathway inserted at the level of the mitral annulus, distal mitral annulus. Am I clear? Yes or no? So this is just, I mean, I'm not trying to say everything in EP, just to give you a bird's eye view that it's not all that complicated. Only thing is you need to devote some time to understand what's going on. Similarly, we are pacing the ventricle here. If you look at this, it's going back, the earliest activation is to the His, ventricle to the atrium at the level of the His is happening early, and then here it's blocked. Can you see this? It's early activation. Here there is V and no A. That is VA block. Ventriculoatrial block has happened, and we can further tease it out whether it's at the level of the His or at the level of the AV node later on, but that becomes too complicated. So, for example, the same atrial His and V that you saw, A His, but the V has started very early. Even before it reached the ventricle, this area in V2, the delta has started. Can you see this? So that means there is an accessory pathway. Physiologically, you expect after the His bundle an isoelectric interval. Because I told you, His is insulated, you don't record any electrogram. Here, before it reached the ventricle through the physiological His bundle, there is an extra pathway which is the result of the accessory pathway, resulting in this delta wave and a very early ventricular activation happening in this. And that is what, and then you move the catheter. For example, here 1-2 happens to be earlier, and you move the catheter to 1-2 compared to the other catheters. So that is how you map where it is coming from. This is just a bird's eye view. For example, here you see that there are more number of atrial electrograms from the ventricle, and this is going at a faster cycle length. You can understand by placing a catheter all along the atrium that this impulse is going from CS 910, that is proximal CS, to the distal CS, and then it is going along the septum, climbing up and coming down, setting up an atrial flutter. So the sequence of activation tells you, you look at it in bipolar electrogram, but the global activation for focal arrhythmia, you look at it in unipolar electrogram. It's just an overview of looking at the tracing. By no means it's complete. People take quite a while to get used to the tracings and interpretation. If there are any questions, we'll be happy to take it.